Okay, so now it's my honor to present the very last paper of the morning session from The Ohio State University, John D. Corrigan. He will present Neurosurgery's Article of the Year for the Stereotactic and Functional groups, Improve function after deep brain stimulation for chronic severe traumatic brain injury.
Thank you very much. I appreciate the opportunity to briefly present our results of this paper. These are our collaborators. I particularly want to acknowledge Dr. Ali Rezai, who very ably led our team and is the first author of the paper. And these are our disclosures. This was primarily funded internally by the Medical Center. So the purpose was to show that we could use deep brain stimulation to improve self-regulation, specifically behavioral self-regulation, following chronic severe traumatic brain injury. Primary objective was safety and feasibility. It was a case series design. 4 patients were eventually implanted. As you can see, there were, the soonest post-injury was 6 years, with one 21 years post. Very severe traumatic brain injuries resulting from motor vehicle crashes. They had all severe disability that was chronic, with cognitive and behavioral impairments, and in some cases motor as well. But they were particularly marked by having behavioral self-regulation problems. 2 had impaired initiative, and 2 were more marked by impulsivity, and more about that in a moment. Our target was the nucleus accumbens, which, as well as the anterior limb of the internal capsule, which gave us the opportunity to affect many prefrontal networks. These are our 4 patients. You can read that if you want. I'll just point out that patient number 2, the first 2 actually were marked by problems of initiative, with patient number 2 having frank abulia. He did not get out of bed on his own in the morning, would sit in front of the TV without it on and not get up to turn it on, despite having perfect motor function. Patients 3 and 4 were marked by disinhibition, with patient 3 having the recognition of not being allowed to go into any establishment in his home community because of his inappropriate sexual remarks, including that his church had asked his parents to not allow him to attend. In terms of outcomes, we had minimal related adverse events. The only serious was an equipment issue that resulted in a premature battery drain. Of the 3 of the 4, after 2 years, were responders. I should add here that we only had to screen 6 individuals to implant 4. 1 individual, we simply could not find a safe route to the target, and the other individual declined the surgery after going through the screening process. As shown here, 3 of our 4 were responders. The primary outcome was the minimally clinically important difference on the Mayo Portland Adaptability Inventory, which is a measure used in chronic brain injury and looks broadly at functional abilities, emotional regulation, as well as one's ability to participate in one's community. Our first participant was our all-star and responded immediately and the most. The one blip was in the Time 5 assessment, which was 2 days after her grandmother died and her mother broke her hip. That was a little bit of an outlier. The others responded, participant number 3 responded post-surgically and remained at that level over the 2 years. Our one non-responder had a very similar pattern of response to patient number 3, and both of those were impulsive patients. Clinically, there was no question that actually all 4 of these individuals improved. Our participant number 2 with the abulia afterwards gets himself out of bed in the morning, goes out, turns on the TV, picks his channel, turns it to the channel he wants and watches it. While his family had previously worried he would starve to death if they ever didn't come home because he wouldn't initiate going to feed himself, now they have actually had to put a lock on the refrigerator because he does initiate going to feed himself. And in some ways that kind of shows one of the things we've learned from this. The next steps are obviously a randomized clinical trial. There's a lot of opportunity for a placebo effect given the amount of attention being given these individuals, and we are planning that randomized clinical trial. We will focus it more strictly on behavioral outcomes, and the third is we will look at the environments to give people the opportunity to actually practice the improved adaptability. Thank you very much.